Well, thank you for coming on Valentine's Day. I hope that this is a night well spent. My theme today really is to hopefully have you guys leave after our 2 hours understanding that it takes both very little and it takes a lot to ensure that moms are healthy so that babies are healthy, because they are our future and they are our next generation. And all that we can do as a village to make that happen for our next generation. So I'm going to begin with by introducing my colleague, Dilys Walker. Dilys is an associate professor in our Department of Obstetrics and Gynecology, as well as an associate professor in global health at the University of Washington School of Public Health. And her goal and her theme really is to impact women's health care here at home and abroad. She practices at Harborview Medical Center, and she specializes in family planning, adolescent reproductive health, and interventions that impact and improve maternal health. So she works in Latin America. I always kind of hear that she's out of town someplace, to someplace very, very fun that I don't get to go to. In training midwives and multi-professional team, again, with the goal to impact women's health and their pregnancies and delivery. And she's also the executive director of Pronto, and I won't try to say that in Spanish because my daughter says that I can't speak Spanish at all, which is true, and which is an obstetric and neonatal emergency training program in Mexico, Guatemala, and soon to be Kenya. She earned her MD at University of California, San Diego, completed her residency in obstetrics at UPenn, and her fellowship in family planning at University of California, San Francisco. And tonight, I welcome Dilys Walker.
Good evening, everybody. It's a real pleasure to have been invited to speak with you tonight about something that I hold very near and dear to my heart, and to share some of our real life experiences with you, which we do in a simulated way. And I will apologize because I am a bit jet lagged, having just got back from Kenya 36 hours ago, so I'm not quite sure what hour it is. So if I don't kind of, my train of thought gets a little bit shaky, please forgive me. How many of you have been in a delivery, seen a delivery, had a baby, seen Discovery Channel? Everyone. So this looks all very familiar to you. So this is sort of the way having a child is in our environment, our world. And what I hope to bring to you tonight is a bit of perspective that our environment and our world is really not what over 90% of the world is dealing with. And most of the pictures that you'll see through my presentation tonight are from where we've been working mostly in Mexico and Guatemala and a few from Kenya. But now I'm going to take you to Guatemala. So this is where women deliver in Huehuetenango in Guatemala, where you can see it's quite different from that beautiful, nice delivery table. You can see in this photo that where women labor and deliver is a far cry from where they labor and deliver here. And what they have, you can see that box of medications over there, is pretty much everything they have to deal with any emergency situation for mother or baby. So as we put that in perspective, I want you to be thinking of what I talk about more from that perspective of this kind of picture where you really have almost nothing, not the perspective of the last delivery you saw on either Discovery Channel or your wife or daughter or anything else, but imagine woman, a family delivering in this kind of context in rural Guatemala. And to put this all in context, we have to kind of go to the Millennium Development Goals. And this was a sort of global partnership with the objective to reduce poverty by 2015. And this was signed in 1990, and we're on the final countdown to try to reach these Millennium Development Goals. And two of them are specifically related to the work I do in developing countries. And one is to reduce under 5 mortality by 2/3, and the other is to reduce maternal mortality by 3/4. And that's by 2015. Most of the countries in the world haven't made it and are not going to make it. This image basically tells you where the global burden of maternal mortality is. And if you see the world, you can see the countries that are in sort of tan and red and yellow and green mean they have high maternal mortality and lots of women are dying, whereas light blue, dark blue are the highest or the lowest levels of maternal mortality. And to put that in context, this shows some of the progress that has been made in some of the countries that have been doing the best towards reaching the Millennium Development Goals, and those that have been the worst. And you can see here that there's a huge range of maternal mortality levels, from quite low in the United States, you see in 1990 it was 12, to someplace like Afghanistan where it's over 1,000. So this maternal mortality, unlike things like vaccination rates or death from diabetes, is different in a developed country to an undeveloped country like Afghanistan, not by a factor of 10, it's more by a factor of 100 or 1,000, where you're having the difference in the rates of women and children that are dying. So you can see that there are some countries that have been making real progress toward Millennium Development Goals, and their maternal mortality rate has dropped significantly. And others, like the US, in which the maternal mortality rate has actually increased over the last 20, 25 years or so. This image just gives you an overall idea of the actual burden of maternal mortality, where you can see that Africa, Asia, are where the great majority of women are dying. And you see a little bit of green and even yellow down in Guatemala where I work. So when you think about that, so what can be done? You know, do we need to bring high-tech US model of obstetric and neonatal care to these developing countries in order to bring the maternal mortality down, or are there easier solutions? And if you start looking at the reasons that women are dying, you see that the majority are due to hemorrhage, preeclampsia, eclampsia, and infection. And on the outside of this circle, you see what kinds of things can be done to prevent those deaths. And you see that for hemorrhage, there are things that are very simple, simply having oxytocin and managing a delivery in an appropriate manner. You have, for preeclampsia, eclampsia, giving magnesium sulfate, which is a cheap drug at the right time in the right place, and you can go a long way towards preventing these deaths. We're not talking about having to have neither obstetrician gynecologists, nor neonatologists, nor specialists in order to make a significant impact. The same goes true for neonatal deaths. Neonatal deaths are particularly due to birth asphyxia, sepsis, and prematurity. Prematurity is a bit harder, but when you talk about birth asphyxia and sepsis, there are pretty simple interventions that if they're done at the right time in the right place, you can go a long way towards saving lives. So let's turn back to maternal mortality. In general, we think of sort of 3 key strategies of how to prevent maternal deaths. One is to prevent unplanned pregnancies, so provide access to family planning, and right there you'll probably decrease by about 25% the maternal deaths in the world. The next is access to a skilled birth attendant at the time of delivery, and that sort of is a whole nother discussion as to what is a skilled birth attendant, but simply finding a way that mothers are attended by somebody who has basic skills in attending a birth and the care of the newborn. And then the third sort of principal intervention is that women actually need timely access to emergency obstetric care. So if they start bleeding, they need somebody there who knows what to do for that and to have the basic resources to prevent that hemorrhage. So I'm going to just sort of take this a little personal. I spent a lot of time in Mexico. I lived there for 11 years and worked closely with the government on assessing their maternal mortality and doing a lot of what we call verbal autopsies. So we review all the death certificates and go to the family and try to assess why that maternal death occurred. Was it because there wasn't access to family planning? Was it because the woman couldn't get to care when she needed it? Or was it because when she got to the care, she didn't get the care she needed? So Guadalupe was one of these women who was 18. She presented to a small hospital called the General Hospital in Chilapa, Guerrero, which is about an hour and a half from Acapulco. She arrived, she had prenatal care, and she arrived to the hospital at about 2 a.m., where she had a blood pressure that was about 170 over 110, extremely high. The intern saw her, recognized that her blood pressure was high, and gave her an antihypertensive medication, and her blood pressure came down. She was watched. She was assessed, she had some labs done, and the intern decided, yes, she did have preeclampsia. She was about 37, 38 weeks pregnant, so term, and he did realize that she probably did need to be delivered. But it was 2 o'clock in the morning, and he didn't want to bother his superior, so he waited till early the next morning to let him know that this woman had come in with a blood pressure of 170 over 110, and had laboratory abnormalities indicating severe preeclampsia. Now, the treatment for that is delivery and treating with magnesium sulfate, as I mentioned. Well, poor Guadalupe didn't get her magnesium sulfate, and she ended up having seizures, convulsions, and had an intracerebral hemorrhage and bleed. And they did an emergency C-section at that point, and she died shortly thereafter. So when you think about Guadalupe and you go back to what happened to her, well, one, she was 18 and she didn't get family planning. She had her prenatal care, and she got to a hospital with a problem before it was a dire emergency. And from there, things deteriorated. So now when we think about what can we do, we're going to go back to Guadalupe and what sort of my attitude is what we can do to prevent those kinds of deaths. But throughout the last 10 to 15 years, as we've been working towards the Millennium Development Goals, there's been lots of new technologies aimed to saving lives of mothers and infants in the developing world. So fairly simple things. We have, low-tech simulation resuscitation babies, which we have one up here that you can see afterwards, where you basically fill the baby with water and can practice neonatal resuscitation. You have, various wind-up materials that usually would require electricity to monitor fetal heart rates. You have various types of solar energy kit. They're developing a new alternative to forceps delivery. So there's been a lot of simple, low-tech solutions to specific problems for mothers. These are for babies. And there have been solutions for mothers. Here we have, on the left, there's something called the non-pneumatic shock garment, so that if a woman is hemorrhaging from an obstetric hemorrhage, you wrap her up in this Velcro suit so that the blood doesn't go out to her extremities and stays near her heart and her head and her abdominal organs. That's life-saving, as is this Bakri balloon, which if you have a woman hemorrhaging after a delivery, you actually put this inside the uterus and blow it up, and it tamponades and it stops the bleeding. So there's all sorts of interventions that are low-tech that can work. Then you have to find out who's going to be using those low-tech interventions and how. This just shows that there's a very clear correlation between having a skilled birth attendant, so having someone there at delivery that knows what they're doing, and maternal mortality. So you can see as the rate of not having a skilled birth attendant at delivery increases, so does both the maternal mortality and the neonatal mortality. So we have the technologies, these great low-tech, low-cost technologies. You have very clear evidence that you need a skilled birth attendant, and if you have a skilled birth attendant, that's going to go a long way. The question comes in, if you have a skilled birth attendant and you have some of this stuff that you need, what happens? Do the two come together, and do you save lives? So going back to Mexico and what was happening with Guadalupe and what's been happening with their whole strategy for maternal mortality is that over the last 30 years, the huge push has been for women to deliver in hospitals or clinics and with a skilled birth attendant. And there, that's with a physician. They've sort of phased out professional midwifery. And most women in Mexico, you can see that the rate of delivering in clinic has increased dramatically. About 85% of women are now delivered by physicians. However, the maternal mortality rate hasn't decreased correspondingly. So if you look at how and where and when are those women dying, we find that 60% of them are average reproductive aged women. You hear that, oh, you've got to worry about those young adolescents and you've got to worry about the older women. But in Mexico, which is now a middle-income country, you're having the majority of the women dying at your standard reproductive age. You're having 90% of them had prenatal care, and they're dying, again, from these preventable causes of hemorrhage and preeclampsia. So if you look at the maternal mortality rate in Mexico with this huge push to have women deliver in clinics, in hospitals, and be attended by physicians, there was a great drop in the maternal mortality rates from the 50s through to the 90s. And from the 90s on, it's been pretty flat. Mexico's been struggling. How are we going to decrease the maternal mortality ratio anymore? Everything they do seem to not have any impact. So it's been hovering right just below, right between 50 and 100. If you go and look at all those deaths and you find, again, where is the obstacle? Is it because they're not getting family planning? Is it because they're not getting to the clinic in time? Or is it because once they get to the clinic, they're not getting the care they need? And this was an evaluation of sort of over a period of a couple of years where they looked very closely at the maternal deaths to try to find out where the problem was. Was it because they didn't get family planning, or was it because they didn't get prenatal care referred? And you can see that the majority of the sort of reasons or the problems where there was an error or a inadequate care was during delivery. So if Mexico wanted to actually decrease the maternal mortality, they had to look at what was going on at the time of delivery. And there was no other way of looking at it other than that. If you have women that have made it to the institutions, they're dying during delivery or something that's occurring around the time of delivery, and they're cared for by physicians, you have to wonder what is the quality of the care that they are getting. And that physician in Mexico and in the rest of the world is considered a skilled birth attendant, which is a health professional with competencies for care during normal birth and capacity to recognize, manage, and refer complications in the woman and the newborn. And my question has always been, when I look at these maternal mortality studies and when I look at all those great fun technologies that I showed you, was that how can you actually be sure that a skilled birth attendant, whether that is a physician in the case of Mexico, or a nurse midwife in the case of Kenya, or a professional midwife in the case of any other country, how do you know that they will know how to use the right technology or the right diagnostic skills for the right problem at the right time? And that is where there's lots of errors occurring. This just gives you a list of what we consider basic emergency obstetric care. If you're providing basic emergency obstetric care, you need to be able to give antibiotics, oxytocics, which we're going to see a little bit later to contract the uterus if you're hemorrhaging, and anticonvulsions to prevent seizures in the case of preeclampsia. Then there's removing the placenta, assisted vaginal delivery, and removal of retained products. That's your basic emergency care. So the question for me when I was working in Mexico was, if you have these problems with quality, you have these providers, and you have these institutions set up with all of the basic ingredients to provide adequate care, why is it they're not, and how can you retrain those providers to do the right thing at the right time? And if you look at the evidence, as we all look at the evidence now, and adult learning theory, it turns that giving out written guides don't do anything. Doing presentations like I'm doing here, which you'll probably forget most of this, don't do a lot either. Repetitive reminders, getting a little bit better, facility visits better, clinical audits, and when you get into interactive sessions and simulation based on learning theory, you start actually seeing an impact in that you can teach them something and expect that there might be a change in their actual practice. And I don't know how many of you were here last year at some of the simulation sessions. Anyone here? Oh, good. So there you saw high-tech simulation. And there's been a huge move towards simulation in teaching medical practice. You know, I learned on people, and the new generation of physicians, nurses, learn in simulation labs. And that is the way that is driven by evidence safely to teach providers how to do the right thing at the right time. But the problem with simulation is that it's very expensive. And I don't know if you saw some of that, the great paraphernalia and those mannequins that talk and their blood pressure goes up and their blood pressure goes down, and you have to come into a fancy sim center like ISIS at the University of Washington or any of these other big centers that have huge multi-million-dollar simulation centers, is a huge obstacle. But the truth is that's the way to teach medical education. And the question was, how can we bring simulation to these rural areas that need to learn better care, and how can we stop sitting down the providers and giving PowerPoint presentations, which is really a waste of time. So we developed a new obstetric simulation-based training program for obstetric and neonatal emergencies, and we're going to do basically what I was doing 2 days ago in Kenya, right up here with some of your help. And it's called Pronto, which is Programa de Rescate Obstétrico y Neonatal Tratamiento Óptimo y Oportuno. Basically, emergency obstetric and neonatal care, timely and optimal treatment. And to do that, we had to develop a simulator. And our simulator is low-tech PartoPants, which you'll also see in action. So the fancy obstetric simulator costs about, the most recent one costs about $250,000. So expecting any developing country in this world to move towards simulation-based training if they have to buy a $250,000 simulator is unrealistic. So we bring our simulator, and our patient actress, who is our great mannequin, actually does breathe and speak, and she wears what we call PartoPants, which is our birth simulator. We go in situ, so we don't take providers out of their setting like we're going to do tonight, but we run simulations where they actually care for women and their infants with the materials that they have. So there's lots of resource limitations, and it doesn't make sense for us to teach the algorithm for hemorrhage if they don't have 3 of the elements in that. So we have to go in there and say, this woman is bleeding. With what you have here today and what you might have tomorrow, how are you going to control that? So what we do is we do a lot of interactive sessions. We do team training, which is a lot of what they spoke about last year at some of the simulation centers, is how do you get teams work together better. So we play these games, and in developing countries, even more so than here in the US, the issues of hierarchy between physicians and nurses and other kinds of practitioners are extreme. So we really have to work towards breaking down that so every member of that team has an equal role and has an equal voice in how to take care of those women. And then we have these sort of skill stations where we practice, and we practice the sort of limited event or the limited skill that we need. And then we do a whole series of simulations where we run postpartum hemorrhage, we do shoulder dystocia, we do preeclampsia. And you can see in the picture, I don't know if you can see very well, but it actually looks pretty real. This is a case that comes into the emergency room, and it's actually domestic violence and an incomplete abortion. And they have to go through, as a team, trying to figure out why is she bleeding in the first trimester. They have to deal with how they're going to deal with the domestic violence situation in the partner. So what we do is we film this, and then we all sit down afterwards and we look at the film and we talk about what happened and how they did it. So this is a birth with a hemorrhage that follows. I'm not sure if we're going to see the full hemorrhage. And this is much better than the very expensive mannequin. Much better. Much more realistic.
Eso, muy bien, ya nació.
So the other thing about our simulations is that the providers never know whether it's going to be a problem with the mother or the baby, and they have to sort of, the truth is you never know whether the mother or the baby is going to have a problem. And this is a delayed postpartum hemorrhage, so she's sort of in recovery, and suddenly she starts bleeding, and they have to go through and figure it out and decide how to manage it and actually go through and manage that hemorrhage. Here we have, this is a neonatal resuscitation. So this baby is not very well and doesn't cry, and they just don't know that until they listen to hear whether or not the baby cries, and they respond to what they see.
90-60 de presión. ¿Qué pulso tiene el niño? ¿Qué frecuencia tiene? Póngale 10 unidades de oxitocina intramuscular. 10 unidades de oxitocina intramuscular. 10 unidades de oxitocina intramuscular. 1, 2 ventila, 1, 2 ventila, 1, 2 ventila, 1, 2 ventila. Frecuencia. And the person in the middle is writing, that's our computer, so we use a whiteboard and a marker so that if they take a blood pressure or they listen to a fetal heart rate, we write it down so that they get that, and then they have to respond to whatever that blood pressure or that reading is. We have a human computer. And this is a cervical laceration. So they've gone through all of the postpartum hemorrhage due to atony, or the uterus not contracting, and now they're finally getting to the fact that, and this patient is actually going into shock. So they haven't gotten to the diagnosis very quickly, and she's already lost a couple of liters of blood. And finally, they're getting to the point of checking to see whether or not she had a laceration in her vagina and her cervix, and that's what's been causing the bleeding all along. And again, we go back through all of this and discuss how they got to that diagnosis. This is a shoulder dystocia, so the head comes out, and then the baby gets stuck. So instead of just sort of giving the PowerPoint of what you do, we set up the simulation where it's going to be a delivery, and they don't know what's going to happen, whether it's going to be a hemorrhage or a dystocia, and they have to go through all of the maneuvers manually in order to release the shoulder dystocia. And again, this little baby that we use, you'll see it up here. You fill it up with water, and it has about the weight of a baby, and it can do heartbeats, and its lungs inflate, and it costs about $100. Oh, this is a preeclamptic seizure. So here they were presented with a woman that had very high blood pressure, and they failed to sort of recognize that as an important sign and give her magnesium sulfate. So as the scenario evolved, she went on and had a seizure, and they had to manage that seizure. So those are some of the simulations. So now I thought it might be fun for us to sort of do a simulation here to see what we basically do in situ, but we're going to do it in situ in the hall, in the auditorium. You ready? Ready? Okay, let's go. Go.
Oh God!
Hi there.
Oh God!
Hi,
The baby's coming.
What's your name?
But the audience
Elizabeth.
Hi, Elizabeth.
Hi. Oh,
Good to
you have to
meet
get
you.
into it too.
I think the baby's coming.
Elton, hi.
Oh
You're
God!
Marina, thank you. Yeah,
Oh,
I'm
it
gonna check your
Okay.
baby.
Oh,
Letting you know. Oh, yeah, she's gonna have her baby. Could you open that kit for me? Can you hear me? So you're doing a great job. We're just gonna get ready to deliver your baby. Just please don't push quite yet. We'll be
Don't
ready to-
push?
Not quite yet.
Don't
I know
push?
you'll feel that urge, but just not quite yet.
It's coming though.
Yes. Okay.
Oh.
All right.
Oh,
So
do you see
when
it?
you feel a contraction, I'm sure
Okay.
you've done this before. So
Okay, I
we'll
think
just
it's coming. I think the
Okay,
contraction's
so-
coming.
Perfect.
Oh, is
yes,
it coming?
So good.
Oh.
Yes, looking
Oh.
amazing.
Oh.
Is you still have a contraction? You can,
Oh, not yet. I think it's back
you
on.
can just let your contraction goes away and put her leg back.
Oh.
Okay, so go ahead and lift her leg.
Oh, it's burning.
And
It's
go ahead
burning.
and push.
Oh.
Okay, here comes your baby.
We're gonna bring your baby right up to your chest. Oh my gosh! Oh, is he healthy? Is he healthy? Is everything okay? Okay. He looks like his father.
Okay, so here, go ahead and cut. So you can just cut right between those. And
I'll disconnect it right here.
Disconnects from the baby. Okay, great.
Yeah.
So we're gonna.
There we go.
All right.
Oh God. Okay. Oh,
Here comes the placenta.
Oh.
Okay.
is everything okay?
Yeah, that's all.
Okay. Okay.
Oh, she's really bleeding. I don't.
What? I'm really bleeding?
Could you call the
My foot's getting wet.
OBGYN
Yeah, can we
for
get
me,
the
please?
OBGYN in here?
Yeah. So what I'm going to do is I'm just looking here.
Okay.
I'm not seeing anything. I'm just going to put my hand in there.
Okay.
Who's in charge?
So I'm E4, I'm a
30
fourth-year
units
med
in the
student.
bag.
This is a 32-year-old woman named Elizabeth. She's G1, now P1. She just delivered her baby. We gave her 20 units of IM oxytocin, and I just hung 20 units in the bag, and she's bleeding.
Keep holding the
and I
baby?
just don't see it.
Okay.
I'm holding her
Do you want me to
uterus.
take
She's
the
got a
baby,
bottom
or you?
Oh, whatever
So
you
I'm afraid
think.
she's got
If you're
it's
feeling
okay.
lightheaded
Just
or
so much
something,
blood, I
we
wasn't
can
sure
move
what
you
you
on.
Okay.
Perfect. You want to take
Let's
your
do
baby?
it
Let's
right,
give
man.
Dad
You'll
the
compression.
baby.
You feel comfortable doing
Yeah,
that?
I'm just holding it right
Perfect.
now.
I just want to make sure that you
We
can give
gave
it
you some
IM,
oxytocin.
okay?
We're giving you
Can you please
different
repeat that?
medications, which cause the
Milligrams
uterus to
IM of
contract.
methadone.
Okay.
Can you
And
tell me when?
normally
Yeah. If you can
that's
give
what
it
happens.
intramuscularly.
Okay.
So now what we're going to do is just very quickly go through a bit of a debrief and talk to those providers and find out a little bit about how it felt, what they were doing, and how, whether there's anything we learned from that scenario, okay? Now, obviously this is very different, but hopefully you got a sense that as things went from being great and fine and baby happy, things started getting tense pretty quickly. And they had to all think and work together. So, how did that feel?
Well, as a provider, I definitely wasn't quite familiar enough with the instruments here, and we had some confusion in the beginning, which was just a little bit, it felt like it impeded my ability to help the patient out. And then as she was bleeding, as a medical student, this is a little bit out of my purview, and so I know how to do a normal delivery, but even I forgot some of the steps to a normal delivery, which would be to give the oxytocin as soon as the baby comes out, before the placenta, and then to do the massage of the uterus just as soon as the placenta comes out, and to give countertraction to the placenta. So I missed many of the steps that you would normally do.
I think you did a great job.
But just, it's always easier to criticize in
It's
hindsight.
easier. I think you did a
Yeah.
great job.
So I was happy to have help. And then it was hard because I didn't really know my teammates very well. And in terms of communication, I think it would have been better if I had had them repeating my directions back to me, just to make sure that we were all on the same page and such.
So
that
some of
hectic
those
scene.
communication tools that can be really important. How about you, Leslie? How did it feel coming into that?
You make me do deliveries in weird places. You know that?
This isn't the first time I've done this to her.
I've been the patient actually as well. I actually thought the teamwork was really good, considering we're a brand new team. Everybody kind of knew what their roles were and were very willing to give suggestions, and they were all very good suggestions. So I really liked the team. This is better than what I've seen in some of our other simulations with like real providers.
People did great, and we're really I saw a lot of mutual support going on there. Dad, how did you feel?
It's very nerve-wracking, but happy the baby came out safely.
Did you feel like your partner was well taken care of?
Yeah,
Okay.
took care of her really well.
Okay. So I think we're going to stop there so we move on. But you can get an idea of how we manage this and how the providers can actually learn something that they will then take with them for the next time that they're stuck with a liter or two of bleeding in front of them. Thank you very much. We'll clean up this very soon.
Maybe you can just put the bag and the
So that's pretty much what we do in rural Kenya, rural Guatemala. We set up these simulations, we take our stuff in 2 suitcases, and we go out there and we do these emergencies. Half of them are related to the mother, and many of them are related also to the baby. We're in the middle of doing a couple of major research projects where, for me, there's a lot of emergency obstetric training programs out there.
Don't mind us.
They're just, fixing things up. But there's really no evidence as to the fact that whether or not they do any good.
So we're in the middle of a couple of implementation projects where we're not just trying to measure what our providers are doing, we're actually trying to measure if there's any difference in the outcomes for the mothers and the baby, and that's going on in Guatemala and in Mexico. Just a couple of other important local efforts in terms of maternal and early neonatal morbidity and mortality. There's the UW Global Center for Integrated Health of Women, Adolescents, and Children, who's focusing on this issue. There's GAPS, which is the Global Alliance to Prevent Prematurity and Stillbirth. And there's also locally PATH, which is a program for applied technology and health. Many of those new gadgets that are out there that are low tech and cheap are developed by PATH. And then finally, to end, I'm going to leave you with a couple of the things some of our providers say.
Es interesante que este tipo de dinámicas, que este tipo de conocimientos a través de vivencias nos permitan fortalecer nuestros conocimientos y sobre todo sensibilizarnos un poquito más, sobre todo el interactuar, sobre todo el estar en contacto con una réplica de paciente. ¿Por qué? Porque el libro no sangra, el libro no grita, el libro no llora, el libro no se...
La repercusión más importante en la formación y en el cambio de actitudes, porque hemos tenido que trabajar, hemos tenido que luchar con vicios que se han formado a través de los años, y creo que una opción para mejorar o para hacer el cambio más formal es la
estos que he tenido y donde he aprendido mucho y en beneficio del paciente.
¿Y has visto cambios en tu hospital?
Sí, muchos cambios. Mejoró el trato digno del paciente. La importancia que tiene el paciente, que no es nada más nuestro lugar de trabajo, que es un ser humano.
Tomado el primer curso de pronto. Al atender mi primer parto fue una primigesta de 15 años de edad. En el momento que lo encuentro en el servicio de urgencias, ya con dilatación completa, pues la pasamos al servicio de expulsión. Y bueno, pues tomo la decisión de no realizarle la episiotomía para valorar si el curso que habíamos tomado era funcional en este sentido y bien realizando todas las maniobras que se nos habían indicado, pues mi sorpresa fue que al atender el parto, pues fue un parto normal, sin desgarro por parte de mi paciente. Claro que la paciente cooperó adecuadamente y pues no hubo desgarro y fue un parto totalmente diferente a los que yo había atendido anteriormente con episiotomía. Y el tercer periodo fue más rápido, la expulsión de la placenta con todos los pasos que se nos indicaron, y pues la recuperación de la paciente fue más favorable y pues pudimos darle de alta favorable.
A diferencia de nosotros, en donde las vivencias prácticamente son lo que nos ponen en un proyector, esto es distinto porque es en vivo donde estamos haciendo la intervención y nos permite interactuar el equipo con todos los demás compañeros de trabajo. Estamos hablando de enfermeras, técnicos, radiólogos, laboratoristas, camilleros y hasta los mismos vigilantes, lo cual nos permite desarrollar mejor.
And with that, I'm going to leave you and tell you thank you. If you have any questions or outlying issues, I'm happy to respond to those.
Where does your funding come from?
Our funding, which is another thing that I'm fairly proud of, has all been, to date, in Mexico. The program began in Mexico, and we were funded initially by the National Institute for Women and the National Center for Gender Equity and Reproductive Health. Since then, in Guatemala, we're getting some funding from the World Health Organization, and in Kenya, we're still looking, but we're confident we're going to get there.
I love your pants, by the way.
Cardo pants.
I've spent some time in Nepal and saw those conditions, with the table. And I found that one of the biggest barriers we faced with women's health was getting them there and getting through some of the cultural barriers. I was wondering if that's being addressed or researched.
When we initiated our program, which there are lots of cultural barriers in these areas, and myself sort of as an outsider, although I was in Mexico for 11 years, I still felt that culturally I couldn't address some of those cultural issues between the indigenous population and the provider population. It turns out we have been dealing with them head on time and time again, and it's actually become a major focus. And the reason is that all of the learning is sort of group process. So we're there to facilitate, and when you see a delivery managed in a very humane, culturally sensitive way, the providers there can't help but notice that it may be different, and vice versa. And we always ask how the person who plays the role of the patient felt, and when things were good and bad. So, in that sense, yeah.
Yes, you mentioned a trained birth assistant. I realize this is a question you can't really answer, but can you make a stab at what's involved in that? How much time it takes? What is involved? If you're not trying to put somebody through 4 years of undergraduate and 4 years of medical school and so on, what is kind of, can you take someone who's almost illiterate, or do they need to have some level of literacy? What does it take to get someone trained to the point where they can handle a situation like this?
That's a great question. And I probably am a bit biased because I spent probably about 6 years working on this as well, trying to convince the Mexican government that physicians were not probably their best option for rural care, because there is a school for professional midwifery there that takes women who've had secondary education, so basically 6th grade education. It teaches them for 3 years, basic competency-based midwifery care, and then it sends them out to home deliveries. So we evaluated them, putting them in clinics and directly comparing their quality of care to physicians. And if you look at all of the evidence-based practices and quality of care parameters, the professional midwives outscored those physicians way, way and above them. Since then, we've gone back to the government, and the government had sort of phased out the role of professional midwife, and they have since legislated a new professional code for professional midwifery again. So I think you can train it. I think they need minimal literacy and probably 2 or 3 years.
2 or 3 years of full-time training then.
That's my opinion.
Okay, thank you very much.
And if you want to come play with our baby, you're welcome to.